I very much approach all patients with a strong eye to really wanting to see the person who has the disorder, the person who has the addiction, not the disorder, but really to focus on who is this person who has had the courage to come to get help for something that they see is not going the direction they want it to go in their life.
I think, you know, most of the ball game is really identification, right? So we have taken the approach in the complex mental illness program that we want to offer consultation, but really what it is a capacity building exercise to have the inpatient and outpatient teams develop core competencies in assessing and making decisions about that, and if they can't handle it, bringing it to our specialists, our subspecialists.
My history taking is different, and the first task is to identify patients who have a concurrent disorder. So often the referral I get from the family doctor doesn't actually include it. And it's a patient is being referred for depression or anxiety or management of their schizophrenia, but it really doesn't emphasize that they're also addicted to smoking or drinking or other substances. So I'm more deliberate in going through a checklist in identifying.
It is my role to make sure that every client coming into CAMH essentially is screened for both their psychiatric or other mental illnesses and their addictions and their use of substances, making no distinction between the two, but really making sure that all clinicians here, when they see any client, understand what is interfering with that person's level of functioning, how much of it are mental health symptoms, how much of it are addiction systems, and how are they interacting with each other.
I assume that everybody walking into the emergency department has a concurrent disorder, and it's woven into my psychiatric history. In the emergency department, we need to be flexible in terms of the care we offer. So if somebody comes in intoxicated, we let them sleep it off until we're able to do a proper assessment. If somebody comes in withdrawing, then we'll manage their withdrawal symptoms in a safe way. Once their withdrawal has been managed, then we'll have a discussion with them about whether they're interested in further support. If detox is all they want, then that's okay too. So there's no standard or bar to determine who's worthy of services and who isn't when they come into the emergency department. We have to be flexible and offer patients what they need in that moment. And if somebody's motivated for change and we can have a discussion with them about that in the emergency department, then it's a victory for us.
From my perspective as the physician-in-chief of CAMH, I think while we are trying to address concurrent disorder, we could do a better job. I think that, as I mentioned, psychiatrists tend to focus too much on the psychiatric problem and to neglect the addiction problem. The addiction group tend to focus on the addiction problem and to neglect the psychiatric problem. And we need to work together to really treat both. Because in people who have concurrent disorder, if you focus on one side or the other of the equation, in the end, you're not going to help them.
Let me talk about some of the reasons why I think we missed the boat here. And as much as we as psychiatrists are unsure whether addictions should or should not be part of psychiatry, I think patients come with the same dilemma. They can identify their depression, sometimes their psychotic symptoms and their anxiety. And they too don't want to talk about their addiction. And they too forget, or because of stigma, don't really want to talk about how much the alcohol, the cocaine, the party drugs actually have affected their lives and changed how they function as people. I think the stigma probably works both ways. For psychiatrists, for some reason, we still struggle with it. Patients have the same struggle. So there in the treatment room, we both don't want to talk about it. So we really need to keep it top of mind and deal with our own countertransference and help the patient with their feelings of shame, of stigma, and actually not even realizing how much an addiction has affected their lives and interfered with their treatment for a mental illness.